like in other countries, want to use the best possible therapies available for our patients. And obviously myeloma is a very good example because of the huge strides that have been made in new therapies for myeloma over the past 10 years or so. And the fact that more and more new treatments are coming on board as well. Obviously, the main aim currently, especially in younger patients, is to achieve MRD negativity, because that seems to be associated with improved progression-free survival and overall survival. So because of that, we are treating our newly diagnosed patients as aggressively as possible to get as good a response as possible. In the past, we weren't able to use a monoclonal antibody, but now we can use daratumumab. So Dara-VTD would be probably our first-line therapy since it was approved over the last few months, with the aim of autologous transplant and then maintenance with lenalidomide. So that would be for our younger patients. Older patients, of course, it depends on frailty and comorbidity. And so one wouldn't be quite as aggressive with treatment with those patients. It's important maybe to perhaps instead of using 3 or 4 therapies together, maybe 1 or 2, because it will improve their chances of being able to tolerate that therapy. Currently, we are not allowed to use monoclonal antibodies up front in older patients. So the kind of treatments we might use up front would be Revlimid, dexamethasone, or VMP for those patients. Obviously, newer agents are coming through, and so for our relapsed refractory patients who failed a lot of treatment, newer therapies where we can, depending on availability from pharma, we have used other treatments like Elexinor, Belantamab, and BiTEs.